रही आवाज?
Is anyone here? 23 participants. Students, do you hear me? Okay, so I'm Dr. Sayyeda Khala Azmat, your today's teacher. According to schedule, this lecture has to be taken by Dr. Badar, but he is busy. So I'm here for you people. Okay, so today our topic is hydrocephalus and its management. Do you people have any idea what is hydrocephalus? Just tell me in yes or no. Students, are you with me? Okay. Okay, so this is the lesson of today's lecture. That tell me and I forget, teach me and I may remember, involve me and I learn. So I'm trying my best. I will try my best to involve you all in today's talk. Before talking about hydrocephalus, we should know what is CSF. Okay? Which is cerebrospinal fluid. What is the composition and formation of CSF? First thing is that this is the third major fluid of our body after blood and urine. Okay? Its total volume in adult is 90 to 150 ml. And in neonates and children, it's 10 to 60 ml. Okay, from where it actually made and what is the flow system of CSF? Actually made in choroid plexus of the ventricles. Then a small amount can also be produced from ependymal cell lining, dural sheets of the peripheral nerve and interstitial spaces. Each day in every human, about 500 ml is produced. Means each day means there is the daily replacement of CSF fluid. It actually produces at the rate of 20 ml per hour in adults. Mostly we talk about in CSF in terms of adults, and somewhere I also show the pediatric readings to you too. So CSF flows through the subarachnoid spaces where volume of 90 to 150 ml is maintained in every second. Again, this value is of adults. It's reabsorbed at the arachnoid villus granulations in the subarachnoid space. Okay. So 500 ml per day production at 20 ml per hour. This is our ventricular system where CSF flows. It may in lateral ventricles in these choroid plexus. From the lateral ventricles, the foramen of Monro, from this foramen of Monro, it come into the third ventricle. And from third ventricle, sylvius duct, from where it come into the fourth ventricle, and from fourth ventricle, it absorbed into the arachnoid granulation and goes into the blood. This is another view of ventricular system. Lateral ventricle, foramen Monro, third ventricle, aqueduct of sylvius, and this is fourth ventricle and spinal canal. This is front view, lateral ventricle, foramen of Monro, third ventricle, Sylvian aqueduct, fourth ventricle. Okay? कोई समझ रहा है? Are you people with me? और बस बढ़ते जाएं. चलो, okay. So, what is the appearance? Normally, it's crystal clear, colorless water होता है. In descriptive terms, of course, these all descriptive terms come when there is some abnormality within the CSF. It can become hazy, cloudy, turbid, milky, bloody, according to the abnormal substances mixed in it. Often quantitated, slight, moderate, marked, or grossly. Okay, we quantitate these terms, that slight hazy, moderately hazy, or slight milky, or moderately and grossly milky, like that. Unclear specimens may contain increased lipids, protein cells, or bacteria, and these things causes the haziness, cloudiness, turbidity, or milkiness in the CSF. Clots indicate that traumatic tap. Means if blood mixed through another method into the CSF, like there is intraventricular bleed or intracerebral bleed, and this blood will come into the CSF, then it didn't clot. But if the blood in the CSF clots, means we have a traumatic tap actually. It's not come from the brain or CSF. It become milky when there are increased lipids. Oily भी हो सकता है अगर contaminate हुआ हो. What is the function of CSF? Actually इसका काम क्या है? It supplies nutrients to the nervous tissue. It removes metabolic waste, and it provides cushioning effect to the brain and other neural tissues. This is just for learning purpose, that how we obtain CSF. We obtain CSF by lumbar puncture. So this is a picture of lumbar puncture, which is showing that we enter from the skin, then we crosses the ligaments of the spine, then the internal ligaments, then we goes into this spinal canal, from where we can obtain CSF for any kind of examination. What are normal contents of CSF? Glucose, which is 60 to 70% of blood glucose levels. Proteins, means this changes according to the blood sugars. If blood sugar is 500, then according to that 500, 60 to 70% approx, you can find 200 milligram or 300 milligram in the CSF. Or if the blood sugars are low, like 60, then what is the 60% of 60? Then you can find 35 to 40 milligram of blood glucose in CSF. But all other substances will remain in normal amount, in the fixed amount, in the fixed range, if CSF is normal. If proteins, lactates, RBS or WBCs amount change within the CSF, that means there is some abnormality. But if the amount of glucose is changed, then first you check the amount of glucose in the blood. Okay. So proteins are 15 to 45, lactates are 11 to 22, RBCs usually normal CSF. There is no. Someone's mic is making very much echo. And WBCs in adults up to 5 mononuclear WBCs per microliter, and in newborn up to 30 mononuclear WBCs per microliter. These are the normal contents. Then the CSF can be infected, and its compositions and biochemistry can be changed according to the type of infection. If the viral infection, then contents are different. In tubercular infection, contents are different, and in fungal infection, contents are different. Now we come on our main topic, that is hydrocephalus. So what is hydrocephalus? This is ventricular enlargement due to altered CSF flow, resorption with or without symptoms of neurological impairment. Okay? What is hydrocephalus? Ventricular enlargement due to altered CSF flow or resorption with or without symptoms or neurological impairment. It depends that how much CSF is accumulated, how much the ventricular systems become enlarged, then according to that symptoms will appear, or maybe patient have a silent hydrocephalus without any symptom. There are two main types of hydrocephalus, obstructive and communicating. I want to go back on the picture of, yes. Obstructive hydrocephalus means the CSF is accumulated due to the obstruction within this ventricular system. If obstruction is within this diagram, then we have obstructive hydrocephalus. But if the problem is outside the diagram, or means when the problem is due to either increase production or reduce absorption in spite of normal flow within the ventricular system, then we call this non-obstructive or communicating. Okay. So where we are? We are here. So obstructive hydrocephalus is impairment of CSF flow within the ventricular system, and impairment of CSF flow or resorption outside the ventricular system causes the communicating hydrocephalus. Impaired flow through the subarachnoid spaces or impaired resorption at the arachnoid granulations causes communicating, or if there is some obstruction and restriction to the flow within the ventricular system, then it's called obstructive hydrocephalus. What is the estimated prevalence of this hydrocephalus? It's 1 to 1.5% per 1,000 population. What are etiologies? It could be congenital, it could be acquired. What are the congenital causes? Aqueductal stenosis due to some infection or any prenatal maternal insult. There could be neural tube defects, arachnoid cyst, congenital arachnoid cyst, or Dandy-Walker syndrome or Chiari malformations. This Dandy-Walker syndrome and Chiari malformations are abnormalities of posterior fossa, which causes the obstruction to the flow of CSF. And what are the acquired causes? There could be intraventricular hemorrhage, meningitis, infection, either viral, bacterial, or tuberculous. Brain tumor can cause acquired hydrocephalus, and head injury can cause acquired hydrocephalus. What are the clinical presentation? Clinical presentation depend according to age. In children where fontanelles are open, the clinical presentations are different, and in adults, after the closing of fontanelles, presentation somewhat different. In young children, what are the presentations? Increased size of head or increased head circumference. Craniofacial disproportion. Head size very large, face is small. Fontanelle full and bulging. Enlargement and engorgement of scalp veins due to backflow of the blood. McKeown signs, which is crackpot sound on percussion of the head, means when you tap or percuss the head of a child with hydrocephalus, you found a crackpot or empty pot sign. There could be sixth nerve palsy, setting sun sign. Setting sun sign का क्या मतलब है? डूबता हुआ सूरज. I will show you the picture. Hyperactive reflexes of the child, irregular respiration, and splaying of cranial sutures. Splaying means separation of cranial sutures. Okay, so this is a picture of hydrocephalic child. Very large head, craniofacial disproportion, small face according to the large head. Eyes are drooping. This is called sunset sign. The veins are engorged and other crackpot signs, and these you can see on a live child. Okay, this is another picture of hydrocephalic child. How we measure the occipitofrontal or fronto-occipital circumference? We have to take the fixed points from the bregma to lambda. Okay, this is the bregma and lambda is in posterior head. From bregma to lambda, you measure the circumference. And what are the signs in the adults? Adults have signs of increased ICP or raised intracranial pressure. So these signs are almost similar for any kind of pathology which is causing raised pressure within the cranium, like headache and vomiting, vertigo, ataxia, nerve palsies, decreased consciousness, and finally patient can have seizure disorder or fits. What are the imaging criteria? I will show you in picture in the next. Size of the temporal horns more than 2 mm. In a normal patient in which there is no hydrocephalus, the temporal horns of lateral ventricles within the scan are usually unremarkable or not seen. But if the temporal horns are visible, then you have to check the patient for developing or developed hydrocephalus. Ratio of frontal horn to internal diameter is more than 0:5. You people don't really worried about these parameters because these are just for the knowledge. No one can ask you at the end कि क्या ratio था. Ballooning of frontal horns, which is Mickey Mouse sign. Periventricular low densities due to the seepage of CSF within the brain parenchyma. Or there is one thing, Ivan ratio, which is also increased, will become more than 0.3. Normally the Ivan ratio is less than 0.3. And what is Ivan ratio? Is frontal horn to biparietal diameter ratio. And sagittal MRI shows thinning of corpus callosum. You just see all these signs. Try to remember if you people scan. Otherwise, don't worry. Which imaging criteria do we need to know for our exams? CT scan or MRI of the brain? Okay, ये जो सारी imaging criteria लिखे हैं, these are for CT scan or MRI. Any one thing. You just try to learn them. Try to understand, otherwise don't worry about that. You all people are not neurosurgeons or neurologists. These all are hydrocephalus scans secondary to many causes. These all are usually obstructive type of hydrocephalus. Something outside the ventricular system compressing the aqueduct sylvius. That's why third ventricle and lateral ventricles enlarges. Is also a blood outside the ventricular system which compressing the ventricular system. Sorry. This is hydrocephalus, enlargement of lateral ventricles. This is the blood within the ventricular system which is causing the hydrocephalus. Okay, so should we move towards the management? You all people understand what is hydrocephalus, what is CSF, how hydrocephalus present. Repeat scan. Beta, in these scans, actually, it's my mistake. I should put first a normal scan, then show you the abnormal scans. But in these scans, the ventricular systems are enlarged. Okay. Then there is something like in these scans, there is blood, which is compressing the ventricular system from the outside. That's why the presence of hydrocephalus. And in this scan and in this scan, the blood is also present within the ventricular system. So especially blood can produce both type of hydrocephalus, like obstructing and non-obstructing. Why I say non-obstructing? Because there is something within the ventricular system also. Oh, sorry, non-obstructing because outside there is a pathology is outside, which is causing the obstruction. Okay. So what is the treatment? Every pathology in the human body should be initially treated with conservative management, or there must be some non-surgical procedures which we should try if we can try. Okay. So what are the non-surgical managements of hydrocephalus? Medical treatments like drugs, acetazolamide, which stop the production of CSF, or we can use diuretic therapies or spinal tap or lumbar puncture, from which we can remove the excessive CSF from the ventricular systems. But of course, there are some indications and contraindications to lumbar puncture. So before doing lumbar puncture, we should know everything. And what are the surgical managements? If patient has hydrocephalus and we are doing surgery, then we have to give the bypass to the CSF to flow from the brain and absorb in some other cavity of the body if it's not normally absorbing into the blood. Okay. So there are 3 to 4 procedures. First, we have endoscopic third ventriculostomy. We can put shunts within the ventricular systems like ventriculoperitoneal shunts, ventriculopleural, ventriculoatrial, LP shunts. Yes, I told you in adults, the signs which are coming from the hydrocephalus are all due to raised ICP. And these are same signs: nausea, vomiting, headache, decreased consciousness, fits, blurring of vision. No. Lumbar puncture is not contraindicated in increased ICP. Lumbar puncture is contraindicated when ICP is raised with obstructive causes. Means if there is obstruction within the ventricular system, then you can't do LP. That I told you in just previous slide, that there is some indications and some contraindications to LP. So we all knows everything or knows all indications and contraindications before doing LP. Okay, not just raised ICP. If raised ICP is due to non-obstructive causes, then you can do the LP. Okay, Sidra. Okay, Sidra. Should we move? Chalo, good. Okay, so we have different procedures like endoscopic third ventriculostomy. We can put shunts. We can open the stenosed aqueduct, but this is now an outdated procedure because of much complications. And we can do choroid plexectomy, means we can uh, remove some amount of choroid plexus, though, so that the main source of CSF production uh, can reduce. Okay, but again, these two lower methods like opening of stenosed aqueduct and choroid plexectomy are now very outdated, and no one is doing the procedures, but they are procedures, so I tell you. This is the most advanced procedure of CSF bypass, which is endoscopic third ventriculostomy. And again, this endoscopic third ventriculostomy, we can just do in the obstructive patients. जिनमें obstructive hydrocephalus होता है, these patients can be treated with endoscopic third ventriculostomy. But in non-obstructive cases where there is a defect in the absorption, then we can't do third ventriculostomy. And in this procedure, we make the opening into the subarachnoid spaces from the ventricular system. Okay, this is the third ventricle. We make a hole in the floor of the third ventricle and open this third ventricle into the subarachnoid space, enlarged subarachnoid space, which is cistern. This is the procedure of third ventriculostomy. We go from the cortex, enter into the lateral ventricle, then from foramen of Monro, we enter into third ventricle, and we make a hole in the floor of the third ventricle and open the third ventricle into the subarachnoid space. But if the what we call the hydrocephalus is communicating variety, means communicating variety में क्या होता है कि there is a disturbance in the absorption. There is no obstruction within the ventricular system, and this actually the disturbance is within this space where the CSF is absorbing, then we can't do this procedure. Okay, these are some pictures of live pictures of endoscopic third ventriculostomy, just for your interest. And this is the shunt. What we do, we make a hole or we make an opening in the skull from where we enter the catheter into the ventricular system. Then we pass this catheter subcutaneously, and finally the lower end open into the peritoneal cavity. Yes, because in communicating hydrocephalus, the defect is in absorption now. There is no obstruction within the ventricular system. So when the absorption is defective, means there is some problem within the subarachnoid space. तो वहीं पे प्रॉब्लम है, वहीं पे जाकर हम ओपन कर देंगे तो हमें कुछ फायदा नहीं मिलेगा ना. एक्चुअली डिजीज मौजूद ही वहां पर है. ठीक है सलीना, डू यू अंडरस्टैंड? So we only done in obstructive cases. Yes, the ETV or endoscopic third ventriculostomy is only done in the obstructive cases, but the procedure of shunt can be done in obstructive and non-obstructive, both types of hydrocephalus, because we bypass the hydrocephalus from the blood to other cavities now. So this is the shunt. Superior or cranial catheter within the ventricular system. We pass it subcutaneously and finally we leave the lower end into the peritoneum, or it can be done into the atrium, which we call ventricular atrial shunt, can be done the pleural cavity, which we call ventricular pleural shunt. Okay, and we can be done it through the LP. Then we say it lumboperitoneal shunt. But the most common procedure which we done is usually ventriculoperitoneal shunt because it is most easiest. Almost every neurosurgeon knows this procedure. Less complications than all other type of shunts, so we do ventriculoperitoneal shunt usually. सही है? So this is again ventricular system. This is again a picture of third ventriculostomy. To teach is to touch life forever. Okay? Or on these procedures cause any brain tissue damage because obviously the ventricles are within the brain. Of course, they can cause, but if we do it with expertise, then the damage will be very minimal. We have specific areas from where we enter, where the elegant areas of brain are not present. So the damage is very minimal and patient has no complications after shunt if we do it expertly. Other shunts replaced? No. We never replace shunts. If the shunt is working, then we can leave it for life. But yes, we have to replace if, of course, this is a foreign body and this is a machine. Machine can stop working. Machine can have complications. So if there is any complication, there is any problem within the shunt system, then maybe we have to replace. But if the shunt is normally working, then we never replace it. If patient is fine, we leave the shunt for life. Okay? So any other question? On one thing which I forget to put in it, there is also a procedure of external ventricular drainage. वो हम उस सूरत में करते हैं when we have infective CSF. So then we can't bypass the infective shunt into any other body cavity. Then we have to take it outside. Insertion of catheter. Complications of insertion of catheter. Mustafa, can you repeat your question? Shahrukh Khan, can obstructing and non-obstructing hydrocephalus exist simultaneously? Of course, can exist. Placement in lateral ventricle or place in any ventricle. For shunt, we place catheter in lateral ventricles only because lateral ventricles have space to keep any catheter in it. Na? Otherwise, we can put in fourth ventricle too. In some cases, when there is trapped ventricle syndrome, this is also a pathology. This is also a term. At time of need, we can put, but lateral ventricles are best place. So, okay, Mustafa, Sarosh, Priyanka. We have time. If you people have questions, then you can ask. ऊपर जाओ